Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. Today I am going to discuss about ADR, adverse drug reaction. Drugs not only produce beneficial effect but also produce harmful effect, deleterious effect, unwanted effect, undesirable effect. Drugs are double-edged weapon. If it is used judiciously, it will produce beneficial effect. If it is used irrationally, then it will produce harmful effect. Harmful effect or deleterious effect or toxic effect. These effects are collectively known as adverse drug reaction. And WHO given a definition of ADR, adverse drug reaction. Any response to a drug which is noxious and unintended and which occurs at doses used in man for prophylaxis, diagnosis or therapy. Once again, any response to a drug which is noxious and unintended and which occurs at doses used in man for prophylaxis, diagnosis or therapy. It needs a bit elaboration. There is any response to a drug which is noxious and unintended. These are the criteria. Which is not response, any response which may be noxious or unintended and which occurs at doses used in man. Which doses? Maybe minimum effective dose, maybe maximum effective dose, maybe therapeutic dose, maybe loading dose, and used for prophylaxis, diagnosis or therapy. So for objective is prophylaxis, diagnosis or therapy. During this time, drugs used at doses and the noxious and unintended effects is known as ADR. So this ADR can be categorized alphabetically like A, B, C, D, E and F. A stands for augmented, B for bizarre, C for continued, D for delayed, E for ending and F for failure. I am going to discuss one by one. Number one, A is augmented, means enhancement of effect. For example, this is the effect produced by therapeutic dose, and this effect is physiological effect, extension of pharmacological effect, and it is undesirable but unavoidable. For example, for ophthalmic purpose, we use atropine drops. Atropine on eye produces dryness of eye, then mydriasis, loss of right reflex, cycloplasia, and increased intraocular pressure. These effects is of concern with eye, but when used for this purpose, it will also produce dryness of mouth, and there will be difficulty in talking, difficulty in deglutition, that is dysphagia and disarticulation. Also, it may cause retention of urine and constipation. Also, it can cause dryness of skin, even may produce atropine fever. We don't want these things. When used for ophthalmic purpose, we don't want these things like effect on mouth, oral cavity, effect on GIT, on bladder and skin, but it will occur. It cannot be separated from ophthalmic effect. Though these effects for ophthalmic purpose is undesirable, but it is unavoidable. So it occurs in therapeutic dose. It is normal pharmacological effect. So this is an example of augmentation. Another example, when you used antihistamine, classical antihistamine, traditional classical antihistamine, that is older antihistamine, They are used for anti-allergic purpose. They are anti-pruritus, anti-cough, anti-cold, anti-motion sickness, anti-emetic, etc. As these drugs are highly lipid soluble, they cross blood-brain barrier and they will produce sedation, hypnosis. The next morning, when a student will come to the school class who took drug in previous night will be inattentive, cannot follow the class because of drowsiness. A laborer in factory cannot be attentive. Skilled workers cannot work. Car driver cannot drive because of drowsiness. If he or she drives, may create accident. So these are the problems. Office worker cannot concentrate in his activities. So these are the problems, and these problems is due to central depression, which is due to its normal effect. At physiological dose, as in therapeutic dose, it will occur. But this cannot be for allergic reaction. We don't want only anti-allergic effect or anti-emetic effect, anti-motion effect. But this effect on CNS cannot be detached from it. These effects is undesirable but unavoidable, and it occurs in therapeutic dose. This is another example. Another example we can give is thiazides or fusimide. They are diuretics and they are used in normal dose, but they will produce hypokalemia. In the collecting tubule, sodium will be reabsorbed in lieu of secretion of potassium. So potassium will be excited from the body and the blood level of potassium will decrease, hypokalemia. It is its normal effect. It is physiological, pharmacological effect. It cannot be separated from the effect of thiazide or fusimide, and this is undesirable, but it is unavoidable. So these are the examples of augmented reaction. Now B stands for Visair. Visair is qualitatively different response. It is a qualitatively different response, and these are of two types. One is immunological, another one is pharmacogenetic. Immunological reaction, here antigen antibody is involved. High percent reaction occurs. Antigen first given, they will produce corresponding antibody, will attack on the mast cell. While subsequent administration of the antigen, then that antibody, as it has own memory, can recognize antibody and react with the antigen and react with the antigen. So this antigen reaction or immunological reaction, it can be categorized as type 1, type 2, type 3 and type 4. Also maybe mild, moderate and severe, and also maybe immediate or delayed. Type 1 reaction, here it is immediate and it is severe form, fulminating form. This is called anaphylaxis. Anaphylactic shock may occur. Drugs like penicillin G, when given first time, it will behave like an antigen, produce antibody which tag on the mast cell, and subsequent administration of this penicillin G, then the antibody will recognize penicillin G and there is interaction between them because of their immunological memory. And complement comes into operation and ultimately mast cell bursts. So from that mast cell, large amount of, profuse amount of histamine, 5-HT release, and that will cause bronchoconstriction, airway obstruction, and peripheral vascular dilatation, peripheral resistance decreases, and oozing of blood from the blood vessels, produce hypovolemic hypotension, and the cause of death, unless managed otherwise, is cardiorespiratory arrest. And that can be managed by adrenaline, which will act as a physiological antagonist and by H1 blocker, because allergic reaction is mediated by H1 receptor and also by glucocorticoid. So this is type 1 reaction, anaphylactic reaction. It is mediated by IgE. Then type 2 reaction, it is antibody-mediated cytotoxicity. Here IgG and IgM is involved. A bit delayed reaction here, and drug alpha-methyl dopa will produce hemolytic anemia in this case. Then there is third reaction, type 3, immune complex type reaction. Here antigen antibody will form large complex, blocks small blood vessels, which will be phagocytosed. There will be release of lysosomal enzymes and inflammation sets in, and that will cause inflammation. There will be serum sickness, there will be vasculitis, pneumonitis, then there will be glomerulonephritis. It occurs further delayed reaction occurs here. And type 4 is lymphocyte mediated reaction. Here there is example is contact dermatitis. It will take 2 to 3 to 4 weeks to occur. So these are the immunological reaction or allergic reaction. It has got some criteria, characteristics, that it occurs in a fraction of the population, and it occurs even in minute dose, and it is a qualitatively different response. And here a sensitizing gap pause is necessary. If the drug is not given in second time, then no reaction will occur, but it is given in second time, reaction will occur. And here antibody is present, antibody involvement occurs, and it is desensitization possible in this case. Now this is one of the visual example. Another reaction will occur in visual reaction, that is pharmacogenetic response. First one is immunological response or hypersensitive reaction, and the subsequent one is a pharmacogenetic response. For example, glucose 6-phosphate dehydrogenase, an enzyme responsible for production of NADPH, nicotinamide adenine dinucleotide phosphate. This enzyme acts as a cofactor for glutathione reductase enzyme. This glutathione reductase enzyme reduces oxyhemoglobin to reduced hemoglobin, which is the functional and active form of RBC. Now, if primaquine or oxidizing drugs are used for certain reason, then there will be increased formation of oxyhemoglobin. So that has to be reduced, and for that reason, increased amount of reduced glutathione is necessary, and to supply it, NADPH is necessary. But if a patient, usually 1 in 10 black of South America, Negroes, they suffer from this disease, that is glucose 6-phosphate dehydrogenase enzyme may be abnormal, may be atypical, or may be deficient. In this situation, there is no adequate supply of NADPH, so there will be no adequate availability of glutathione reductase. So the oxidized form of RBC will not be reduced, converted to reduced form. As oxidized form is fragile, so RBC undergoes hemolysis. So in this way, primaquine will produce hemolytic anemia. This is a genetic condition. Another example is glucose 6-phosphatase. First one is glucose 6-phosphate dehydrogenase, and the next is glucose 6-phosphatase. This enzyme, it is a key enzyme or rate limiting step for conversion of glucose 6-phosphate to glucose, and this is utilized in glycogenolysis reaction. We know glucagon or adrenaline will produce hyperglycemia, activates glycogenolysis. But there are some patients who have abnormal or atypical or absent glucose 6-phosphate enzyme. So as a result, this glucose 6-phosphatase enzyme is deficient, so there will be no conversion of glucose 6-phosphate to glucose, as a result of which glycogen will be stored in the liver, producing von Gierke's disease or glycogen storage disease. This is another example of pharmacogenetic response. Another example, succinylcholine, which is a depolarizing skeletal muscle relaxant used for endoscopic examination, and when this drug is given intravenously, it will produce temporary apnea because it will produce diaphragm temporarily, and it will be hydrolyzed by enzyme pseudocholinesterase or plasma cholinesterase. But in some patients there may be abnormal or atypical plasma cholinesterase enzyme. So in that situation, the administration of succinylcholine may produce prolonged apnea instead of short apnea, because this drug will not be hydrolyzed by the pseudocholinesterase enzyme, which is absent due to genetic cause. So there will be prolonged apnea, diaphragm will be paralyzed, and unless managed properly, even may lead to death of the patient. So these are the examples of pharmacogenetic response. Here the response is qualitatively different response occur, and occurs in a limited few number of cases. This will occur. Those who have enzyme deficiency due to genetic cause. Now 3C. C is continued. There are so many diseases where drug has to be continued for long period. For example, hypertension, epilepsy, psychiatric problem, tuberculosis, leprosy, where drug has to be given for prolonged period. We know if we use drug in normal dose for prolonged period, there is chance of developing toxicity. If the drug is used in larger dose, in higher dose, then within short period there is development of toxicity. But if it is used in therapeutic dose for prolonged period, naturally it will produce adverse effects. For example, in case of anti-tubercular therapy, first line of drugs are 5. When you use these drugs for longer period, then there is definite toxicity will occur. So as for example, INH will produce liver damage. Also, it will produce peripheral neuropathy. Rifampicin will also produce liver damage. Then pyrazinamide produce liver damage and hyperuricemia leading to gout. Ethambutol will produce color blindness, loss of visual acuity, and streptomycin will produce ototoxicity, vesticochlear nerve damage, and nephrotoxicity. So these effects occurs due to continued use of drug. Similarly, chlorpromazine can produce cholestatic jaundice. Clozapine can produce agranulocytosis. So when drug is used for prolonged period, they will produce harmful effect. Now D means delayed. Here delayed reaction occur, and it is usually, if the example will be for teratogenesis, and will be carcinogenicity, mutagenicity. A pregnant mother in first trimester, if a pregnant mother in first trimester, if she uses some drug due to some reason, then this drug will cross placental barrier, and during this time, first trimester, organogenesis occurs. Organ development and differentiation, which is known as organogenesis, occurs, and this drug, after entering into the fetus, then it will interfere this fetal development, this organogenetic process. And when this fetus will be delivered on the earth as baby, she or he will come with, with congenital abnormalities. So this abnormalities is known as teratogenic effect, and the drug is known teratose. So after a long gap, about 6 month gap, we are getting this teratogenic result of teratogenic effect. So that's why during first trimester, drug should be avoided as far as possible unless otherwise indicated. But those drugs necessary to maintain pregnancy, that can be continued. Another example is a newly married couple. They do not want baby now, so the female partner used to take oral or injectable contraceptives for several years. Later on, they changes their decision and they withdraw the contraceptives. Now, when she crosses 35 or after 30 or near about 40, then there may be some problems appears in the genitalia. There may be cancer of the cervix, cancer of uterus, there may be cancer of breast. This thing occurs after a long gap, and the mutagenicity occurs and carcinogenicity occurs. So D, that is teratogenicity, mutagenicity and carcinogenicity, it will occur. Now E means ending of drug. Usually we cannot abrupt drugs. Usually we should not abrupt drugs or suddenly. Abrupt withdrawal of drugs should not be withdrawn abruptly, especially for the glucocorticoids. That should be tapering the dose or tail the dose gradually, slowly. The drug has to be withdrawn by tapering the dose. Otherwise, adrenal crisis will occur. Hypothalamo, hypopituitary, adrenal storm leading to adrenal crisis will occur. To minimize that, we have to tapering the dose. Similarly, antihypertensive drugs, anti-diabetic drugs, anti-epileptic drugs, these drugs, once started, has to be continued throughout life. So, if patient feels better and suddenly withdraws the drug, then there may be rebound phenomenon, increased hypertension, increased blood sugar level, increased convulsion will occur. So, tapering the dose, tail the dose should be done. Sudden withdrawal of drug should not be advocated. Now, F means failure. Treatment is given, but there may be, blood pressure may not be controlled. Treatment is given, but diabetes may not be controlled. Treatment is given, but the epileptic fit does not control. These things may occur. So these are the failure of therapy. But here, most important thing is antimicrobial failure. Antimicrobial failure is a great problem, global problem. And once upon a time, microbiome was sensitive to that drug, but now this drug is not sensitive. Why? There may be spontaneous mutation. Spontaneous mutation occurs within the bacteria, so it will develop resistance. It may so happen that the drug cannot enter into the bacteria, or if it enters into the bacteria, they will be pumped out by the bacteria, or their metabolic system is changed in such a way that drug cannot interact with this, cannot act as its false substrate, or their target organs may be changed. 30 years or somebody, 50 years or somebody may be changed, so that drug cannot bind with their respective binding site. So these are the changes which can occur that leads to resistance, or microorganisms may produce elaborate enzymes which can destroy the drug. So in this way, resistance can occur. So to minimize this resistance, we have to use drugs cautiously. We have to prescribe drug rationally. Judicious use of drug will produce beneficial effect, and irrational use of drug will produce harmful effect. And we know that's why rational use of drug requires that patient receives medication appropriate to their clinical need at doses that meet their own their own requirement for an adequate period of time and at the lowest cost to them and their community. Now the criteria of RUD means rational use of drugs are appropriate diagnosis, appropriate indication, appropriate patient, appropriate drug. Under this drug, appropriate dose, appropriate route, appropriate time and appropriate duration. Along with this, appropriate information. So, knowing this knowledge, we have rational prescribing can be practiced by knowing RUD, rational use of drugs. We hope that at the end of the course, you will be able to know adequate knowledge about RUD so that you will become a rational prescriber. And I am coming to end of these topics, and my next topics will be on short notes on general pharmacology. That will be inshallah on Thursday, that is 23rd instant. May Allah bless you. Assalamu alaikum wa rahmatullahi wa barakatuh.